Welcome to everyone joining the webinar. We'll give people a couple more minutes to log on and then we'll get started. Welcome to everyone joining. We'll give people about a minute or so to log on and then we'll get started. Welcome to everybody joining us. We'll give it about a minute or so, let people log on, and then we'll get started. Welcome to everyone joining. We'll give it a few more seconds here, let people log on, and then we'll get started. Okay, so I think we'll go ahead and get started. So hello to everybody that's saying hi in the chat. Appreciate that. So welcome to this webinar on core ventilation concepts for sleep technologists. My name is Brad Sexauer, and I'll be moderating this webinar today. And before we begin, keep in mind that you can ask a question at any point during the webinar. Just click on the Q&A button at the bottom of your screen and type in your question. We'll answer those questions at the end of the webinar. If you have any technical difficulties, go ahead and type those into the chat box. And so you have your Q&A button at the bottom of the screen, and then you also, where most of you have found, you found the chat box where we're all saying hi. We'll give Lisa a few more minutes to advance the slides. There we go. You have a fancy animation. So Lisa has one of the best presentations that I've seen so far. This is, and you could already tell that this is going to be a fun presentation. So there's all the housekeeping stuff. So questions in the Q&A box. Any issues, we have people on the backside who can help out with that. So put your issues into the chat feature. And then this course is accredited by the AARC for 1 contact hour, and approval is pending through the AAST. To receive your certificate, fill out the evaluation form that pops up at the bottom of your screen under the Resources tab. If you happen to miss it, you'll also receive a link tomorrow in your follow-up email. Complete the form, include your AARC or your AAST number if you have one. You'll receive a certificate by email. Just be sure to complete that evaluation to receive your certificate. And then we will be following up with a follow-up email and evaluation when that AAST number is approved. So be on the lookout for that. And then if you're watching as a group, please provide your email, your facility name, and the total number of attendees that are in your group. Go ahead and put that information into the Q&A box. After the webinar, Syntech Education will send a link to that evaluation form to the email that you provide, so you could share it with everyone in your group so they can complete the evaluation to get their CE certificate. Now I'm happy to introduce our speaker for today, Lisa DeGuzman. With 38 years in healthcare, Lisa has spent all but the first 3 in neonatal and pediatric medicine. She was a neonatal respiratory therapist for 15 years before she transitioned to pediatric sleep medicine with Nemours Children's Hospital 21 years ago. She worked as an acquisition and scoring technologist for 9 years before transitioning to a leadership role in 2014. During this time, the sleep lab at Nemours has moved, expanded, and has experienced a 500% growth in volume of studies per year. Along with her work in the sleep lab, Lisa has previously served as a subject matter expert for the BRPT to analyze and standardize settings for the RPSGT credentialing exam and to develop the CCSCH exam. So with that, I'd like to welcome Lisa. And Lisa, I'll turn it over to you.
Hi, can you guys hear me?
Sounds good.
Right, perfect. Welcome, everybody. I am happy to be here, even more so than usual, because I'm just coming off a week and a half of pretty severe COVID. It did not take my voice, though, so I'm here to talk about some sleep and ventilation. And I did want to say this is going to be a very colorful, retro, fun presentation on my slide deck. But we are talking about a very serious and very important part of sleep medicine and respiratory care. So it's definitely not to take away from the importance of what we do, but I am all about making it more interesting. If you can see, even dress, that's going to match my graphics along the way. So let's get going. So disclosures, I do have a consulting agreement with Centec, and some of you may have seen webinars before, so I am able to do some conference speaking and present some webinars on CO2 monitoring, sleep lab in general, pediatric sleep. So it's been a good couple of years that we've been working together. Our learning objectives for today. We're going to look at the fundamentals of ventilation and respiratory physiology. So breathing and the parts and pieces of us in the lungs and upper airway and what it takes to get there. We're going to look at gas exchange, where that happens, and look at ventilatory measurements. So how we measure it, how we monitor it, and ultimately how we treat it. Laser pointers escaped. All right, so we're going to look at some tools for monitoring and optimizing ventilation in the sleep lab. We will quickly just review events. I have other webinars that kind of get into that a little more between adults and peds, but we'll touch on that quickly. Look at hypo and even hyperventilation in the sleep lab, how we recognize that, monitor, and treat it. How we use tools and devices to monitor and treat, actually to effectively support PAP and vent titrations when we find hypoventilation or obstructive apnea, central apnea. So, and then we'll look at some troubleshooting therapy as well. And finally, we'll wrap up with just some general managing sleep disordered breathing in the sleep lab, the common PAP modalities. Some of you, I think, will probably use at least half of them on a daily basis. The other two we'll see. There's a poll question in there coming about that later. And then we'll talk about some invasive and non-invasive ventilation. So the first poll question, and if you know what that is in the upper right-hand corner, then you've been around a long time and are a dinosaur like me. But how many years of sleep experience do you have in the sleep lab? And we're going to give you about a minute to answer that. And we'll look at if you come from the yard dart dinosaur days, or if you are new to the field and bringing some fresh eyes and excitement from a new perspective. I think that it's important to have both as we work in this field. I've never regretted the switch that I made from neonatal intensive care, which I loved, to sleep. But it definitely, the senior therapists and technologists are the backbone, and we really need new blood coming in, even later in life, new transitions into this field. All right, so almost half are in their first year, so that's amazing. Welcome. I'm glad you're here, and hopefully this helps. For my veterans coming in at about 40%, so this is going to be a review for you probably on the most part. I'm sure there are many of you that could teach me a few things. So if you've noticed anything along the way or have anything to add that we can include in future webinars, for sure, comment, email, let me know. And then we have some in the middle. So great mix. All right, so starting off, ventilation and the respiratory physiology that gets us there. So Syntec actually created some diagrams that I'm going to be using, some animated diagrams, and they did a great job with it. I zhuzhed them up a little bit with the retro colors and backgrounds. But to begin with, we're going to look at really the basics of gas exchange. So in this infographic, the green has our upper airway and lungs. We're going to see the oxygen passing to the heart, which is represented there in red. It's going to be sent out to the body in yellow, and then you're going to see it return in blue. So deoxygenated blood carrying CO2 back in the opposite direction. So again, oxygenation, it's inhaled into the lungs. It diffuses from the alveoli, and we're going to look at those things a little more closer as we go through. It enters the bloodstream, sent out to the body, and then our body uses oxygen, and a byproduct of cell metabolization is CO2. So that is dumped back into the bloodstream, returns, and then crosses at the alveolar sacs and is released through our exhalation. So we saw the in, and then there is the exhalation coming out. So simple, but very effective way of kind of looking how the oxygen comes in and the CO2 leaves the body. And that's what we call ventilation. So if you were lucky enough to have a Polaroid camera back in the day, you too could have seen inside the body for this type of view. So a little more 3D of what we looked at in the previous slide, coming down the trachea into the bronchi, and then eventually ending up in these alveolar sacs where gas exchange happens. Back on retro TV, we always watch these very technical shows that peeked right on into the lungs. So here, what we're seeing, the capillaries in red, so blood flowing through there, and then the alveoli sac at the bottom, little red dots going across are your oxygen, blue coming across is carbon dioxide, and it's a very thin membrane, one cell thick. So it has to be intact, it has to be working great. We have to have good oxygen getting there, and we have to have good blood flow and perfusion to get it back out. Everything works together to have us standing here, sitting here, watching this webinar and making the magic happen today. Some terminology that we use in ventilation. So tidal volume, and there are several ways that you'll see in this written. I am a dinosaur of old school, and I like my big V subscript T, but I have written it, I think, as big V little t throughout the rest of the presentation. So tidal volume is the amount of gas inhaled and exhaled while we breathe. The breath in and the breath out. When we talk about normals, though, we talk about ideal body weight. And as you know, working in a sleep lab, we have a high percentage of our population that is obese. We also have medical conditions where people are smaller than they should be because of growth issues or wasting, failure to thrive, those kind of things. So what we use is ideal weight when we calculate these things. So some base guidelines pretty much accepted, but we do bounce in and out of them based on disease process, sometimes size of the patient or what's going on. But adults, 6 to 8 milliliters per kilo, children, 5 to 8. And again, children is kind of a broad range, up to about 12 years old. So it can be lower, it can be higher based on their size. And then infants, really 3 to 8, but 4 to 8. And again, like with a preemie, that's going to be a little different than a full-term infant. So we're always looking at size for that ideal weight on height. So, and we're going to look at that in a second too. Respiratory rate. We all know that. This should be a review for everyone. It's the number of breaths that you take each minute. Just a week ago with COVID, I was breathing many more times a minute than I am this week. So if our lungs are not either ventilating well or we're not perfusing well, our inspiratory rate typically increases to try to help compensate and get things moving through. Normal breath rates, again, these are ranges and based on pretty healthy people. So adults 12 to 20, and And this is at rest. We typically want to take respiratory rate at rest. School age kids, 18 to 30, they're healthy. When we're looking at preschool age, 1 to 5-year-olds, 24 to 40, and then infants, 30 to 50, sometimes even 60. Minute ventilation, and you will see this abbreviated as big V, little e, or sometimes MV, but it is the amount of ventilation or volume that a person breathes in and out per minute. So the normals for minute ventilation, again, are based on ideal body weights. So when we refer back to the tidal volume box and multiply it times the breaths, then we're going to get our minute volume. So as an example, and especially when we're talking about ideal body weights, this is a pretty standard formula. So it divides male and female, and IBW, ideal body weight, is listed in kilograms here. So by using this formula, you take your height, which is in the parentheses, subtract 152 from it. Your next math function would be to multiply it times the 0.9 and then add it to 50. So we did a little sample here. So I took a 6-foot tall male patient, 72 inches, and converted that to centimeters, 182.88. Just rounded it down to 182. So we go back to the parentheses, 182 minus 52 gives us 30. Back to the multiplication, so that 30 times 0.9 is 27. And then back to the male formula, which is 50 plus that number. So 50 plus 27 gives us 77 kilograms for our ideal body weight. Now, at 6 feet tall, somebody could weigh 77 kilos. They could be 2, 3, 4 times that amount as well. So we're not going to triple our tidal volume based on weight. We're going to do it by anatomical size, typically. Hopefully that made sense. Oh, there's the graphic that matches my sweater there. I don't want anybody to miss it. So what is alveolar ventilation? We're going to start there and talk about that a little more. So it's the amount of air available for gas exchange in the alveoli. And those are those little sacs that we saw in the video. It was that smooth one cell layer where the O2 and the CO2 particles are moving, or molecules are moving across. And it starts just a little bit above those. And we're going to look at a graphic next on that. But it determines, our alveolar ventilation determines the efficiency of oxygen delivery and carbon dioxide removal. And it's critical in maintaining gas exchange. So if something is off, and we'll look at some slides showing that, we're not going to have good gas exchange, and we're going to see kind of a spiral down from there. So alveolar ventilation, it's influenced by several factors. This can be your respiratory rate. If it's too high or too low, is going to change it. Your tidal volume, if that is too high or too low, it can change it. And then dead space in the respiratory system. So we're going to talk about dead space in a minute too. And here, what is dead space? So there's actually three kinds. So anatomic, you're going to see on this graphic on the left here, is in red at the top. And that starts at the trachea, and it's going to go all the way down to the terminal bronchioles. This is where air moves in and out. Actually, it's starting at the mouth and nose, excuse me, coming down the trachea. So anatomical dead space is starting wherever we're breathing in from. So from the mouth, nose, all the way down to the terminal bronchioles. Once we get into the respiratory bronchioles, that's where the magic happens. This is where gas exchange is going to start going. Oxygen in, carbon dioxide out. So we have alveolar dead space that can happen in that lower part of the diagram. And then we have, so anatomic dead space, if something's going on in the upper airways, that's preventing air from getting in and out. Alveolar, if it's happening down past the respiratory bronchioles. And then mechanical is actually your dead space that we add if you had a mask and tubing, or an endotracheal tube that sticks out and tubing. That's called mechanical dead space. And I will say most devices nowadays do compensate for the mechanical dead space, but it is part of dead space when we're looking at dead space in general. One more thing about this little graph here, it shows from the trachea coming down in one pass. By the time you make it to the alveolar sacs, there are approximately 23 splits or 23 generations of airways that split off from the top to the bottom. So a lot of splitting off, each split splits off until we finally get down to those alveolar ducts and sacs. Why does it matter? An increase in dead space, when we're talking about that, can lead to a decrease in alveolar ventilation. It's going to reduce the amount of air we're breathing in and exchanging at that alveolar level, oxygen in, CO2 out. So diseases that increase dead space or conditions that increase dead space, they're going to affect that dead space to tidal volume ratio. So we don't want to have more. So typical dead space, anatomical dead space is a 20 to 30%. And again, based on condition, body type, and sometimes some genetic situations. So roughly 20 to 30%. So if dead space is getting higher, it's going to impact ventilation and how the patient does overall, the gas efficiency. All right, so here's some more graphics that Syntec was able to provide. And they do a really great job. You have your key up there in the left-hand corner. So oxygen's going to be in orange, an orangey red, and CO2s are going to be in blue. This is going to be an example of normal VQ ratio, V being our ventilation and Q being our perfusion. So that's the blood coming through those capillaries. This is a patient with normal perfusion ratio. The lungs are working and circulation is doing well. So oxygen is going to flow in. It's going to run through, circulating throughout the body and come back. And then CO2 is going to diffuse out. So we've got good oxygen coming in and the CO2 leaving as it should. For this one, we have VQ mismatch. So we're looking at some reduced flow. So we have some impaired flow, not complete issue, and we have normal blood flow. So a patient may have COPD, maybe some OSA. So that's not every minute of every day. It's not even every minute of every night, but they may have REM-based OSA. It may be throughout the night. So periodic episodes of impaired airflow. Asthma is another situation where that can happen, but our perfusion is doing well. So we have reduced diffusion because something in that ventilation part of this VQ is not operating as it should. So it's still working, but not optimally. We have VQ mismatch in shunting. So here we see the alveolar sac laying there on the capillary bed. We have no airflow, but we have normal blood flow. So if no airflow can get through some of these alveoli, it can be caused by pneumonia with some consolidation and fluid and mucus, an airway obstruction in some part of the lung, or full airway obstruction. Actually, we're going to, I think, see full airway obstruction, collapsed alveoli due to disease process, and some pulmonary edema can cause this. So air comes in, but it can't get through. CO2 can't get out. So in those alveolar areas, parts of the lung that are damaged or suffering at the time, we're not going to have the exchange we need. No oxygen getting in that area, no CO2 getting out. Another VQ mismatch is, so we have impaired blood flow, but we're breathing normally. So maybe it's a patient with no upper airway obstructions, nothing going on respiratory wise, but they do have some impaired blood flow. This can sometimes be caused by too much pressure with positive pressure ventilation. If a patient has cardiac output issues, even vasoconstriction due to hypoxemia when everything kind of pulls in to protect the vital organs. So here we see oxygen's coming in. Some's getting through. It's not the airway that's working. It's just not diffusing well with the perfusion in some areas. And then, of course, the CO2 is coming back and coming out a little bit spotty. So this is an example of reduced diffusion through. And then dead space. So we talked about dead space, and that could definitely cause problems. Mismatches here, we have no blood flow and normal airflow. So for whatever reason, the dead space is not allowing anything. Oxygen's not getting in that area. The circulation is kind of oozing out. It's pulled away. It can be a pulmonary embolus. You can have reduced perfusion problems with patients that get worse. So in these areas, again, airflow is okay. Maybe we've stented that airway open and we're doing a great job of getting oxygen, oxygen in and CO2 out, but it's not able to cross that alveolar membrane. So factors that can affect alveolar ventilation, and we've talked about them a little bit. So sleep in general can affect it. There's different stages of sleep. For those of you that are sleep technologists and working in sleep lab, we know this. Muscles relax, especially during REM. We become paralyzed. Our voluntary muscles go into that relaxed state. We're always wanting to see REM supine sleep because that's typically where we see the worst of it. Although you will have patients that do poorly in other stages and then completely improve in REM, but typically REM is the worst. So sleep in and of itself can cause problems with alveolar ventilation. Age plays a factor. So not only is our beautiful young skin, our elasticity, all the things that go along with aging, it's also happening in our lungs and perfusion as well. So we also lose the elasticity and the ability for those lungs to snap back the way they used to. They stretch and they just sometimes don't respond the way they should. Sleep conditions. So a patient with OSA, so when they go to sleep, if they're blocking their airway partially, fully, intermittently, frequently, sleep conditions can cause this. Positional obstruction can happen too. So again, on your back supine is typically where a lot of people have the most amount of issues, but we can also get our face in the pillow. Babies, when they're very young, can get their face stuck in the pillow. So sleep in general, things that can happen during sleep, sleep disordered breathing can affect alveolar ventilation. COPD, and also our neuromuscular diseases. So these are things that happen over time, they worsen over time, but they can definitely affect alveolar ventilation, whether it be from the ventilation side of it, where the air is not getting, or it's getting trapped before it leaves effectively, and then not allowing us to breathe back in well, or in the neuromuscular conditions, we're having body wasting, muscle wasting, so we just don't have that strength to really move the volume in like we should. So as these records spin on the turntable of issues, and there's more than what was just on there, some of us may have no records spinning. You're just listening to the radio. You're doing fine. Some of us may have one single on there, and then others are rotating a lot of discs, waiting for the next one to drop. How we address alveolar ventilation in the sleep lab, though, is what we're going to look at now. So we use positive airway pressure, right? All the PAPs. It provides continuous or variable pressure, and we'll talk about those, to open and stent that upper airway. The goal is to stent it open and prevent collapse in patients with sleep disordered breathing. It's typically what we're looking at. We're seeing sicker and sicker patients that come through the sleep lab. So in addition to opening that airway, we're also having to watch those hemodynamic conditions, risks of, or maybe already strokes, congestive heart failure, all kinds of things going on. So as the patients get sicker that come to us, since home sleep studies are kind of filtering out those simpler cases, we're spinning a lot of those discs and trying to keep the music going, right? Commonly, we're using PAP again for obstructive sleep apnea and sleep disordered breathing, central and mixed sleep apnea, so a little more complex on the mixed apnea, and we'll look at the different modes, and patients with hypoventilation. The common modes of PAP therapy that are used in the lab. So CPAP and BiPAP, I would say everyone should be using if you're in sleep. CPAP's commonly your first step. So if you're diagnosed with OSA, outside of the pediatric lab, unless a patient has no tonsils or very benign, 0, maybe +1 tonsils, a tonsillectomy and or adenoidectomy is typically the first line of defense. But that being done, and if there's still residual issues or in your adult populations, or if you've already had your tonsils and adenoids removed, CPAP's where we're commonly going to start. BiPAP is used for patients with higher pressure. Sometimes they're not able to tolerate the high CPAP pressures, or we need to go beyond that. Or they're experiencing hypoventilation. So it gives us that bi-level, mimicking the breath to help us increase the pressure when we breathe in, decrease when we breathe out to make it a little easier. I did not include, one thing I didn't include in this presentation is KPAP. So it's kind of a reversal, and I've not used it, so I'm not real familiar with it, but that has shown up, and that's increased pressure on exhalation and decreased pressure on exhalation. So that is something that we'll look at in the future for my presentations. But so CPAP, BiPAP, and then when we move into central and mixed apnea patients, our complex patients, ASV and the ST mode on BiPAP can help when we start throwing central apneas into the mix. Volume assured modes, your AVAPs, your IVAPs, those we actually use a lot in our lab. We have a lot of neuromuscular patients, respiratory failure, restrictive lung disease, and occasionally some obesity hypoventilation syndrome. Those patients with hypoventilation syndromes, and especially if they're complex, can get a lot of improvement and relief from your volume assured PAP. So ventilator settings, this is just a nice little chart here. So we're going to be setting inspiratory positive airway pressure, known as IPAP, and that's the high pressure during inhalation. And again, for sleep technologists, this is a review. Stay with me. It's what we use every day. Expiratory positive airway pressure, EPAP, that's going to be your lower pressure during exhalation. Pressure support helps, it's added to your EPAP, and that helps support the airway in between. So it's additional pressure added to your EPAP, also known as PEEP, and it helps support patients in between. Our backup respiratory rate, if you have patients who do fall off during the night, whether it be from a congenital issue like congenital central hypoventilation syndrome, neuromuscular patients that get tired, having that backup rate assures that we're going to at least get some airflow moving. Rise time is how quickly the machine is going to get to the IPAP pressure. And then inspiratory time is how long each inhalation lasts. So we're going to go through each of the PAP modes very quickly here. CPAP, as you can see on the left there, it's just a continuous pressure. There is no fluctuation. It delivers a fixed, predetermined level of air. So, and it just remains stable. Inhalation, exhalation, you're just getting that positive pressure at that level. We set pressure and occasionally FiO2, if we need to bleed in some oxygen. There are also ramp settings or some relief if patients need it during the time they're falling asleep. There's also on the exhalation, you can reduce exhalation a little bit if the patients need that for comfort. These are used, again, first line for sleep disordered breathing. And typically for insurance purposes, you do have to show that they failed CPAP before you can move on to BiPAP. Next one we'll look at is bilevel. BiPAP, bilevel airway pressure. You can see on the graphic. So your inspiratory pressure is high, and then it drops down for exhalation and just cycles back and forth. Regular BiPAP is triggered spontaneously. So it delivers the higher pressure and then the lower pressure, but the patient is setting the pace. So it gives the high breath when they breathe in and then backs off to the lower pressure when they exhale. We set IPAP and EPAP on those machines. And again, sometimes with a little bit of a ramp, sometimes adding some oxygen in there. Patients not tolerating high CPAP pressures, sometimes we'll go to BiPAP. Patients needing some ventilatory support with that inhalation, exhalation help. And then we have BiPAP ST. So patients with central apnea or periods of central apnea, we can add the backup rate so that if they do fall off occasionally, they do have some central apnea, it will push those bilevel breaths. Now, you often are not getting the same full breaths that they're taking on their own, but it does provide some backup support there. APAP, automatic pressure or automatic positive airway pressure. It fluctuates, and this is a good thing. Not everyone has the same sleep disordered breathing in all stages of sleep. Some are very REM dependent. That's when it's the worst. Then every other stage they're fine. So with AutoPAP, it varies the pressure and it responds to the patient's breathing pattern. You can also set ST on this, so you can give a backup rate. So if for some reason, if you've got a rate of 10 set and 6 seconds go by, it is going to give a breath. It's going to push a breath through. We set pressure max and pressure min settings. So if you want your patient to range between 4 and 12 or 6 and 18, whatever pressure based on, hopefully on a sleep study or in a titration in the lab, that doesn't always happen, but you can set a wide range, and that way the machine will just automatically adjust to what the patient needs, and you see that on the graphic there. And again, used for patients that don't need the same support through all stages of sleep. And AutoPAP is often what's ordered with home sleep testing. They're not in the lab getting that titration, so a lot of providers will just set them up with AutoPAP after that. Now we have some advanced modes, and so we're starting with ASV, and that's adaptive servo ventilation. And you can see on the graphic that it goes based on the patient's breath. So if the patient doesn't breathe enough, it gives a little more and supports him. If he is breathing fine on his own, it will back off and let him do the work. So it stabilizes ventilation by adjusting pressure support in between as he's breathing, and it's based on flow. So this is looking at flow and rate in the algorithm. So it does allow for an ST backup rate. And typically we see this for central and complex sleep. So mixed apneas, you're having obstruction and you're having some central components. This can be harmful to some patients though. So AFE is not indicated if you have symptomatic heart failure, chronic heart failure, and ejection fraction comes into play. So that 45% is crucial. So patients sometimes do not qualify and could actually cause more harm and have had some death if they meet that criteria. So ASV doesn't work for everyone. Profound and chronic hypoventilation, it's not always effective and can do more damage. It can knock out some respiratory drive, that the buildup of CO2 and the decrease of oxygen. Help. Moderate to severe COPD sometimes is not benefited. Chronically elevated CO2, and our neuromuscular and restrictive lung disease patients don't always do well on ASV. So, and we're going to talk about in a little bit, I thought I had the volume slide here. So with our neuromuscular patients, and I went through the list, obstructive or obesity, hypoventilation syndrome, restrictive lung, chronic respiratory failure. These are patients that we often go to volume ventilation in our lab, AVAPs, IVAPs. And we'll talk about that a little more. Challenges. Most of our patients have challenges with PAP, right? So congestion can affect it, dry mouth that I'm having now. So air blowing through there, creating the dry mouth and upper airway can cause problems for people. We do have humidity that you use at home that can help. Mask leaks if you don't have a well-fitting mask. If you're on a nasal mask and your mouth pops open all the time, that can create a leak. I don't know that excessive noise is much of an issue anymore. These machines used to be really, really loud. I feel like they're super quiet now. As someone who loves a little white noise, I don't know that that's a big issue anymore. But if you are disturbed by a little bit of extra noise, that cycling of the machine sometimes can be disruptive. Patients who have claustrophobia can often feel like if they're wearing PAP, that they'll panic. and then too much pressure. So there's just patients that either always feel like it's too much pressure, or if we get to a therapeutic level that is actually opening their airways, if they wake up aroused, they just can't handle that pressure. So lots of challenges with PEP therapy sometimes. So we're going to look at monitoring ventilation during sleep studies. Tools and devices. These would be straight from the 60s, 70s, and 80s here with that boombox going right into the 80s. So tools and devices that directly tell us what's going on in the respiratory aspect of sleep study. Our airflow sensors, we're going to look at some of those. Our respiratory effort belts, we're going to monitor that. We want to know effort as well as airflow. We're going to look at oxygen saturation always. We want to know, is the oxygen getting into the body and perfusing out to all the body parts, right? We need to know if it's crossing that membrane. Carbon dioxide levels also. We need to know that those are being released at normal levels. If we're ventilating well, then oxygen should go in at normal levels. We should have normal sats, and our CO2 coming out should come out well and have normal CO2 levels. If oxygen is low, carbon dioxide is high, then we've got a problem going on. And then respiratory rate. Again, some disease process can affect respiratory rate up or down. So we need to monitor these modalities or these observations in the sleep lab. And then I did have some indirectly, some made both lists. So oxygen saturation can indirectly tell you about ventilation, because we've had kids who desat during the night, but they have no respiratory events. Their airways are good. So that can be a perfusion issue. It could be a cardiac issue. There's other things going on. You can also have a sat probe off. So sometimes it looks like your patient is desatting, or they're laying on the arm where it is on the hand. Sometimes it's not really an issue at all. So indirectly, sometimes it can tell us. Again, respiratory rate, depending, we have patients who breathe quicker, some who breathe slower, especially it slows down during sleep. Again, it can change in different stages. So rates changing don't necessarily mean that there's a problem going on, but it is something that either very directly or indirectly can help us. And then snoring. Snoring, loud snoring or no snoring on a snoring patient can tell us there's a severe problem going on, or they're snoring that is just benign. And we have patients who snore and their oxygen's good, CO2 is good, and their airways are good. They don't have many, if any, respiratory events. So when you fully obstruct, you're snoring, snoring, snoring up to it, fully obstruct, and now there's no more snoring. So if your snoring goes away on a patient with obstructive apnea, that may be the pinnacle or the worst part of the obstruction. So high and low can be a problem. All right. We are going to look at respiratory events in the sleep lab. So we're looking for OSA, obstructive sleep apnea, our most common. We're looking for central sleep apnea in the sleep lab. We're looking for hypopnea in the sleep lab, and that's partial airway obstruction. We're looking at mixed apnea. So those have both a central and an obstructive event, or part to it in the event. And then we have raras. So those are arousals that are caused by respiratory events that don't meet the criteria of hypopnea or apnea. So it's an arousal that the patient has, but we don't have that 30% drop in flow to be a hypopnea. And this is reported out as RDI, respiratory disturbance index. It doesn't count typically towards insurance and helping get the diagnosis, but we do score them, and they are an important part of what we monitor. And then finally, snoring. So again, snoring is going to tell us how noisy that airway is. If you have a nice airway while you're awake and it closes down to coffee straw size when you go into REM, you're like breathing through a coffee straw, things are going to get loud. If you have a floppy airway in there, things are going to start vibrating, tongue falling back, those kind of things are going to cause snoring. Congestion can also cause snoring, as well as positions. Scoring rules by the ASM. I have other webinars that go through this a little more in-depthly, but we have the adults and the pediatric events here. The main difference is adults look for 10% in their respiratory events, whereas pediatrics look at 2 breaths long. So that can be 4 seconds, it can be 10 seconds or more based on their respiratory rate. Adult scoring does have 1A and 1A and 1B, I think. I put 2A there. Anyway, 3% or an arousal, or if you do the Medicare rules, it's 4% with no arousal. For hypopneas, we're just looking for 2 breaths of 30% drop with a 3% DSAT or an arousal. So a little bit of difference there. All right, the things we monitor ventilation with, and these should look familiar to those of you working in sleep. Our respiratory effort is detected by esophageal manometry, which I can tell you in 21 years I have not dealt with. Dual RIP belts. We also have dual PVDF belts. So what we use in our lab is actually the roll of belts there, the RIP belts, and they hook to those sensors, so we cut them to fit. And it has the wire that runs through them, stretches when the patient breathes in and out, and gives us an effort signal for the chest, the abdomen, and the sum combo. Ours are disposable, and then the belt you see below that is a non-disposable belt. So same type of situation, just non-disposable. And this is going to it's going to help us detect obstruction. So if you have effort, patient's trying to breathe, but no flow is coming through, then we have obstruction or partial obstruction. Central, we're going to see it flat on both. We're going to see flat belts. We're going to see flat airflow. So it helps us pick apart what type of event we're looking at. Here's our flow devices. So we have thermal sensors, and we use the ones like on the top picture there. So they sit on the lip, they register temperature. So hot air coming out and cool air coming across it when we breathe in, and it makes a flow tracing based on temperature and flow coming in and out of the mouth and nose. We also have pressure transducers, and those are typically your more reliable one as long as you can keep a cannula in place and get that reading. So in the picture on the right, you actually see a combo unit that's got a thermistor and a pressure transducer together. PTAFs. We have C-flow if they're on CPAP, BiPAP, and then end titles do have a flow channel. They're not very sensitive, and if your end title's going in and out, you're not going to have a good flow. But we do have them, and again, they're going to help us pick up the obstructive versus the central. Snore mics, there's all kinds of different types. We use the disposables in the top picture. We used to use the ones you clean on the bottom, but they get placed right over where someone would pick up the vibrations of snoring. There are acoustic sensors, piezoelectric sensors, and nasal pressure transducers also. So you can also pick up snore from that, from your pressure transducer. And again, we're looking for increase, decrease, or cessation of snoring. And of course, central apnea would show cessation. We're SAT probes, they're everywhere in the hospital and the sleep lab. We use the disposable ones on the bottom. This is how we typically, all of us, look at oxygenation in the patient. Rarely you might do an APG, we don't in our lab. On rare occasions, it's been ordered afterwards, not during a sleep study. And again, event detection, it's gonna decrease with events typically, especially if they're frequent or they're long. And central apnea, same thing. We're gonna have a decrease based on the length and the frequency. Although I will say healthy kids, they can do some crazy events and not see much move on the SAT probe. When we're looking at the ventilation, the release of CO2, how that moves across, we have transcutaneous monitoring that we can use, end tidal, and then on rare occasions, a blood gas. So CO2 is going to help us look at hypoventilation. So with obstructive events, you may see a decrease in it or an increase in CO2, but if they're frequently arousing and waking up, they're going to blow it off with the events, and you may not see an increase in CO2. Otherwise, it should increase. But if they're rousing a lot and doing a lot of catch-up breathing, you may not see that climb. Central events, if they're long enough and frequent enough, you should see a climb in your CO2 value. Hypo and hyperventilation. The partial pressure of CO2 at the end of exhalation is what end-tidal CO2 reads. Transcutaneous is looking at the estimate of your arterial CO2 measured through the skin. Both have advantages and disadvantages. Transcutaneous comes in with more comfort. It's not interrupted with split night, CPAP, BiPAP. It's not dependent on anything on the face. So if it's on your clavicle or your forehead, wherever you've got it, doesn't really matter what you're doing with the airway, mouth breathing, nose breathing, it's going to pick up for you. Restless patients, though, you may have to change that sensor during the night, or if the area where you have the sensor is not well perfused, that can affect it. End tidal, it's immediate. Whatever's coming out of their breath at that time, it's going to read. It does have a flow channel, so that's an advantage. It's also non-invasive, but not as comfortable. So we have a lot of young and older kids that fight that cannula. So comfort's an issue there. If they position and move around, sometimes that cannula it acts with suction, so it can get suctioned down to the skin or the mucus inside the nose, that kind of thing. Mouth breathers, even though we do have the drops, the oral drops on the cannulas, don't always pick up well. And then if you have to add CPAP, you're going to wash it out if it's underneath, or it's not going to work at all. So, so for my laser pointer there, indicators of hypoventilation. High CO2 levels persistently and or frequently. Oxygen desaturations, despite the treatment of respiratory events, can often mean hypoventilation, and frequent headaches in the morning or whenever a patient wakes up and has fatigue can also be a sign of hypoventilation. Associated conditions, obesity, hypoventilation syndrome, your neuromuscular disorders, restrictive lung, pulmonary and obstructive lung disease, your CNS conditions like stroke, congenital central hypoventilation syndrome, ROHAD, traumatic brain injury. And then we also have, drug issues, toxic issues, fentanyls, opioids, heroin, alcohol. Those can all cause decreased ventilation and hypoventilation as well. So ventilation with PAP titration. Real quick, we have a poll question. What modes do you titrate in your lab? And then we're going to go through them real quick. Give you just a minute to answer that. All right, so as suspected, CPAP, BiPAP for the win, and a good amount, really. Half of you out there are using volume ventilation and ASV. So that's great. So the goals, whenever we're using PAP therapy, we want to eliminate, at least improve apneas, hypopneas, and snoring. We want to provide enough pressure to open up that airway and keep it open. We want to restore normal oxygenation, obviously. We want our patients oxygenated well. We want to improve ventilation, which means reducing that CO2, getting rid of that, allowing the lungs to move those in and out, and with the oxygen out with the CO2. And we want to maximize patient comfort and adherence. So we want to find the lowest pressure that fixes the problem or greatly reduces the problem, but that they can still have compliance. So here we are, we're coming at them with the best answer ever. We're going to fix your CPAP. We're going to see patients like this, hopefully wearing it. We're ideally going to see patients sleeping very comfortably like that. But I did want to show you real quick too, as I went through looking for pictures to license for this. They snuck two crazy ones right there that you could buy for examples. And here you see on the lady, that strap on the left cheek is not even touching her. And the man on the right should be obvious what the problem there is, but these are being sold for PAP presentations. So he's got that mask on upside down. But this is the goal. This is what we want to feel like in the morning. We want to feel like grabbing our guitar, sitting on top of our VW bus and having a great day, right? We want to wake up refreshed and feeling good. When we treat with CPAP, and these are just the standard protocols, we always want to make, we want to make at least 5 minutes ideally before you make a change, preferably more. We're going to increase by 1. Adults, sometimes a little bit more. If we're running out of time in peds, sometimes we do a little more. Your max pressures are a little higher in adults than kids. When we do increases, for kids under 12, it's 1 OA versus 2 OAs for older people. 2 OHs versus 3 hypopneas for older. 3 versus 5 raras. The 3 minutes of snoring is the same, loud snoring. And we're going to decrease PAP if the patient awakens, feels like it's too high. If they have a long time without events, you can try to creep it down a little bit, but you want to make sure you're capturing REM if you're creeping it down. And we also usually bring it down if they're having centrals that are not resolved. BiPAP, pretty much the same thing. BiPAP comes in if they're not tolerating high CPAP pressures, you can transfer them over, or if we need to deal with hypoventilation and help move that CO2 out. So basically the same increases. The high pressures, again, for adults, a little bit higher than the peds population, and you want to maintain a 4 to 10 split in your BiPAP. So 8/4 is typically what we start at, unless it's a very large adult sized patient in the pediatric lab. We want to keep our CO2s under control and increase for CO2s. We're going to increase for our events. You can increase EPAP for DSATs and sometimes IPAP, right? If we need a little more PEEP to help hold those alveoli open, the EPAP can help. And we're going to add rate for centrals. AVAPs and IVAPs. Here, the goal is volume. So it helps reduce the high pressures. We have a lot of patients that transition over to volume ventilation. Keeps the pressures low, ensures a set tidal volume. You set IPAP max, min, EPAP rate is set unless you're using AE, which is auto EPAP, so you can set a range, rate, inspiratory time, and then like on the AVAPS machines, they have AVAPS rate, which just tells you how quickly it's going to make changes. Most hypoventilation situations do respond well to this, especially if you're creeping up into high pressures. ASV, same goals, but it looks at flow versus tidal volume. So it's not going to guarantee tidal volume. It's going to look at rate and flow and respond breath by breath for that. And again, ASV is going to be contraindicated in patients with that ejection fraction less than 45%. So very important on that. In summary, so we talked about alveolar ventilation and dead space. Physiologic dead space is your anatomical and your alveolar dead space added together. We also occasionally have the mechanical dead space. And it's important to understand these problems, are they, it's not always just the airway. It can be perfusion. It can be at that alveolar level from lung disease or trauma, scar tissue, those kind of things. We looked at the guidelines for monitoring respiratory and some of the tools we use. Common modes of PAP therapy, which I think everybody was familiar with, or most of you were, so that's great. And we had a groovy time, right? So I want to thank you for joining. If you have questions, you can reach out. Again, my disclosures, I do consult for Suntech with these webinars and occasionally conference speaking. And I'm going to hand it over to Brad.
Great. Thank you, Lisa, so much for that wonderful presentation. A lot of great comments in the chat. Just really a great comprehensive presentation with really good information. Um, just as a reminder, to receive your certificate, you'll need to fill out the evaluation form. It popped up in the resources tab. So if you click there, you'll see the evaluation. And then if you happen to miss it there, you're also going to receive a link in your follow-up email tomorrow. And remember, if you missed it in the beginning of the presentation, we're still waiting on the AAST CEU number. So once we get that, we will follow up with the evaluation for those needing the to get that certificate for the AAST. And we are at the top of the hour, so I want to be respectful of everyone's time. We did get a few questions coming in, some really good questions, and just so you know, we will look over the Q&A that came through, and we'll reach out to you to answer those questions. We'll get Lisa's thoughts on the answers to those. So we'll be bugging you with those, Lisa. But thank
That's
you.
fine. It ran a little long, sorry.
No, it was a very comprehensive, great information. And again, like you have a lot of kudos in the chat. So wonderful presentation. And yeah, we'll do it later again tonight. So thanks everyone for joining.
Bye, have a great day. Don't
Bye.
get COVID.